name is Dr. Aaron Ritter. I'm a PGY3 resident, and this is my presentation on total ankle replacements. First, I want to talk about the numbers. According to the New York Times, on January 18, 2010, an article stated that 770,000 total hip and knee replacements are performed annually, and that approximately 25,000 ankle arthrodesis were done last year. 2 million patients visit the doctor each year for ankle pain, and 50,000 of these patients suffer from end-stage grade 4 ankle arthritis. 4,400 patients are expected to undergo ankle replacement in the next year. Total ankle replacements began with the first total ankle replacement implanted in 1970 in Hamburg, Germany, using a converted inverted hip prosthesis. In the 1980s, engineers designed a 3-component ankle joint with a mobile bearing. The goals with this mobile bearing joint were conservation of bone, rotational axis, tibial alignment of the foot, and biological fixation. The indications for total ankle replacement are rheumatoid arthritis with an average AOFAS score of 81.6. And these account for approximately 48% of all total ankle replacements. Osteoarthritis accounts for 24% of all total ankle arthritis, or total ankle replacements, with an average AOFAS score of 86. And rheumatoid arthritis accounts for 21% of total ankle replacements, with an average AOFAS score of 75. Quantifying ankle arthritis has been done by several physicians and institutions. The German SF36 scoring system, there's the ankle osteoarthritis scale, the AOS, the American Orthopedic Foot and Ankle Score, the AOFAS, and the Visual Analog American Orthopedic Foot and Ankle Score, the VAAOFAS. The ankle osteoarthritis scale is a tool that's used for assessing symptomatic ankle arthritis, a modification of the foot function index. Measures pain, disability with a 95% confidence interval. The scale is from 0 to 100, with the higher score indicating increased pain and disability, with a normal average score ranging from 10 to 15. Some authors have suggested that clinical studies using these instruments should be adjusted for concomitant musculoskeletal disease. There's the Kellgren-Lawrence grading scale for ankle osteoarthritis, with grade 1 indicating doubtful narrowing of space, possible osteoarthritic lipping. Grade 2 defines is definite osteophytes with definite narrowing of the joint spaces. Grade 3 is moderate, multiple osteophytes, definite narrowing of the joint space, and some sclerosis, and possible deformity of bone contour, with grade 4 indicating large osteophytes, marked narrowing of joint space, severe sclerosis, and definite deformity of the bone contour. The treatment of osteoarthritis is varied. There is the oral medications, including the non-steroidal anti-inflammatories, and the use of steroids. Orthotic devices, such as custom orthotic inserts and bracing, such as Arizona braces or functional AFOs. Immobilization, steroid injections, and physical therapy. Additional treatment of osteoarthritis includes hyaluronic acid injections, Synvisc or Euflexa, arthrodiastasis of the ankle joint, ankle arthrodesis or fusion of the ankle joint, and total ankle replacement, which is also a joint destructive technique, whereas hyaluronic acid, arthrodiastasis are joint sparing. Total ankle replacements are varied and include the in-bone by Wright Medical, which was FDA approved in 2005 as an alternative to ankle arthrodesis. Total ankle implant, the saltotolaris implant by Tournier, after 9 years of use in Europe, was approved in the United States in December 2006 for use in ankle replacement. The Agility by DePuy was approved in 2002 and has been used in multiple ankle arthrodesis since that time. The STAR by Small Bone Innovations, SBI, was approved on May 27, 2009 by the FDA and is a 3-component mobile bearing system. The Integra by Life Sciences Holdings Corporation is not currently FDA approved, but has been used in trials. There's also the buccal pappus, which is similar to the in-bone, has a tibial stem and is not currently FDA approved, but like the STAR, contains a mobile bearing. The ankle prosthesis itself, when considering the 3-component prosthesis, which has become the gold standard in ankle replacement, the results of long-term trials show 5-year survivorship of 98% and 10-year survivorship of 80%. Anatomical motion of the 3-component ankle implant allows for physiological ligament loading and balancing. Osseous malalignment of the foot causes overload of these ligaments, muscles, and tendons, contributing to early implant failure. The contraindications to total ankle replacement include infection, open fracture, significant bone loss, poor skin condition, unstable joints, or bone immaturity or allergies to metal, pregnancy, peripheral arterial disease, and unrealistic patient expectations should also be considered as contraindications. Some of the complications of the total ankle replacements include rheumatoid arthritis, which can present a unique challenge, including involvement of other lower extremity joints, as well as delayed healing. The post-traumatic arthritis requires careful imaging prior to implantation, and vascular studies must be used to assess, and infection must also be ruled out in any arthropathy. The success of total ankle replacements, factors that contribute to the success of the procedure are, one, the condition of quality of bone, the type and severity of arthritis, the condition of muscles and ligaments surrounding the ankle, age, activity level, and overall health, and commitment to rehabilitation.